First of all, I'd actually like to extend my gratitude to Nolex for inviting me to speak here today, and to all of you, the audience, for actually being here to listen. My name's Becky Hill. I'm actually representing the Central Sterilizing Club, and I've got like 30 years of experience in water quality assurance in the healthcare environment. I'm passionate about healthcare. I'm passionate about infection prevention control in the built environment. So everyone in this room knows that prevention is better than cure. But how do we actually prevent something from happening if we haven't first experienced it and the consequences of it and understood the part that we actually individually play? So Sir Francis Bacon in 1597, he publishes works from which the quote, "Knowledge itself is power." And it's often been repeated and I believe misinterpreted to mean that knowing is enough to make change. But the world is filled with people who know a lot, but what really makes the difference are the actions or the inactions that are subsequently taken. So I'd just like to explore some key historical events that went on to inform the understanding of hazards of water to public health. So between 1846 and 1860, there was a cholera pandemic, which was sweeping the world. And germ theory, interestingly, hadn't been fully developed by that time. In London, cholera was claiming around about 14,000 lives. And Dr. John Snow, a physician at the time, he was the one who noticed a pattern. He started asking questions, and he identified that the source of contamination was from the water supply and not from the widely held belief that transmission was via unclean air. So water has been recognised for its significance in early civilizations, and various methods were employed to transport water, to deliver fresh water and take sewage away. And in the UK, pipework was first laid in the 1300s, and by the 1600s, wastewater was managed through basic filtration. But the hazards to public health through water was not fully registered until John Snow was able to demonstrate that water from the Broad Street pump in Soho became contaminated from a leaking cesspit, and was how the cholera bacteria was actually being transmitted. But it was the smell of 1858, which was 4 years later, after Snow's findings, that really prompted the action, another year later, of investing in rebuilding sewers and creating pumping stations to divert that sewage away from populated areas. And it's actually this that was credited with the reduction in cholera. So it's interesting, it took 5 years for action to happen. And then it was another 31 years in 1885 that Theodore Escherichs described E. coli as an organism appearing in large quantities in feces, that bacterial surveillance became a routine undertaking. And then another 60 years before the law was formed in the form of the 1945 Water Act, to be passed, that would then go on to become the present-day Water Supply, Water Quality Regulations 2018, describing the permissible qualities of water suitable for human consumption, which we all describe as wholesome or potable water fit for drinking. Now, in high-income nations of the world, we can expect that our potable water will be delivered at our consumer taps through the various municipal water suppliers, and that it will be free from enterococci and E. coli. Just those two organisms. The water provider's responsibility stops at our doorsteps, and what happens to the water quality onwards becomes our responsibility. So how we store it, how we distribute it, how we use it, how we dispose of it, how we monitor it, and how we treat it, it is all our individual responsibility. So in a complex environment such as healthcare, where microbial safeguarding is a priority, you'll appreciate that what everybody does or doesn't do matters. From a public health perspective, the next major milestone in knowledge translating to action came in 1976 in Philadelphia at a convention of the American Legion, where 29 people, mostly men, of the 182 reported cases of pneumonia died. The first reported cases of Pontiac fever occurred 8 years earlier, and it wasn't until 1976 when Legionella bacteria was discovered that the link was made that these two diseases were created by the same organism. This bacterium naturally occurs in water and can contaminate hot water tanks, hot tubs, cooling towers, air conditioners. Basically, where there is water, there is a potential hazard. It is typically transmitted via direct person. Isn't typically transmitted via direct person-to-person contact, but it's usually spread by breathing in mist, which contains the bacteria. So when risk assessing, we have to look at all areas where the potential of aerosolization production can occur. So think about what was going on with COVID and the ventilation that we've just discussed downstairs. 15 years later, in 1991, the first edition of the Health and Safety Executive Guidance for Legionella Control in Hot and Cold Water Surfaces, Air Conditioning and Industrial Cooling Systems was published. With today's guidance as HSG 274, L8 Approved Code of Practice, and the recently published British Standards Institute 8680, Parts 1 and 2, and BSI 8580, which is the supplementary supporting document for Pseudomonas risk assessment. Now, water falls into building and estates infrastructure, and therefore the primary responsibility for management falls with estates and facilities, who you hope know what the engineering controls are and measures required to be in place, and how what they do impacts on your clinical work. But this premise is based on having certain knowledge, and as I said at the beginning, how do we really know anything without having had the experience of an event? So we think we've got public hazards of water under control. Yeah? No. And then boom. In 2012, 3 babies die at 2 Northern Ireland hospitals during 2011 and 2012. And what's interesting is in August 2010, the Department of Health commissioned a review of evidence related to contaminated water supplies in response to a number of reported Pseudomonas outbreaks across England and Wales. It's very sad that it takes a serious incident to wake people up to the various risks that others have been warning and telling you all about in advance, as this letter, which was published in the Internal Medicine of 2002, highlighted. The upside of this incident, though I'm sure that the parents and people involved in the inquiry at the time didn't see it that way, nevertheless prompted an addendum to HTM 0401, which would be SHTM 0401 here in Scotland. That predominantly focused on Legionella, but with the new guidance, it incorporated Pseudomonas aeruginosa surveillance and testing, albeit narrowing the focus on registered augmented care units. It's interesting, really, that that's not been extended to elderly long-term care facilities, where quite often residents have broken skin challenges, depressed immunity, and staff may not be as competent in their care and observations. But community care takes their lead from acute care, so how well are we doing in our mandate to prevent avoidable harm from waterborne infections today? Not so well. So new buildings are contaminated, not just the old ones. We cannot use that excuse anymore. It's not just Legionella and Pseudomonas that are a problem. These are indicators of compromised design, systems, processes and operations in which all the other opportunistic waterborne pathogens will come out to play. We've been focusing on hot and cold water supplies, which is only one aspect of the water pathway in healthcare. But what about the various equipment that's attached to those supplies? What about the drainage points? And what about the human interactions of the staff, the patients and the visitors with all of these things? The Health and Safety at Work Act puts the focus on safety in the work environment, under which Legionella control primarily sits, and the law applies to all market areas. In healthcare, the Health and Social Care Act's regulated activities and the Code of Practice for Prevention and Control of Avoidable Healthcare-Associated Infections encompasses the much broader microbiological spectrum with the mandate first do no harm. A priority expressed on the understanding that patients coming into your care who are already sick are also vulnerable to contracting secondary illnesses which they didn't come in with. So what goes wrong? The healthcare environment is complex, with many different disciplines employing people from diverse backgrounds, and it's a safety-critical environment. The stakes are high. When is there not a crisis to manage? During these challenges, it's very easy to lose sight of the important actions and situational awareness that helps us to prepare to prevent avoidable harm. And as Ronald Reagan once said, when you're up to your neck in alligators, it's hard to remember that your initial objective was to drain the swamp. I think you've probably all felt that this past couple of years with COVID. We talk about a whole team approach, but what does that look like and how do we keep it alive and engaged? At the heart of water management today is the Water Safety Plan, and for that plan to work, the Water Safety Group must comprise of representatives from different specialist fields. It requires all stakeholders to see beyond their own disciplines and to begin to understand each other's language to bridge the gap between clinical and engineering governance. Working together is key. So who is in your team? Is everyone clear about their roles and responsibilities? What are the core values and the culture of that team? Do you attend the meetings? And if you do attend the meetings, do they feel like a waste of your time? And if so, what is actually being done to promote engagement and focus on continuous quality improvement and initiatives over firefighting? At the end of the day, operational systems and processes only work if the people required to do the work are aligned and engaged. We can choose to close our eyes, stick our heads in the sand, and hope that we never have to do with anything, in which case we fail to prepare for the potential of an adverse event. Or we can embrace Murphy's Law, accepting that we are not going to eliminate human error and instead design the interventions with the people that will be required to implement the actions in the real world. By engaging them in optimizing the processes, creating a shared meaning and understanding, improving both staff and patient safety and experience, whilst improving the overall system performance. This is called human factors engineering, which applies scientific methods to the design and evaluation of tasks, jobs, equipment, environments, and systems. So circling back to the beginning of the talk and the title, Prevention or Control, why did I put or instead of and? In order to prevent anything, we must first have awareness either in direct experience or shared experience, which in turn provides a source of knowledge of sequence of events and their consequences. From this, we predict the risks for the future potential and instigate control measures based on that moment in time. We are preparing to prevent. But once we've put the control measures in place, is that it? Do we regularly evaluate and reassess whether these controls are effectively working, or do we get distracted and wait for the next crisis before we review them again? History seems to suggest the latter is true, and COVID has highlighted quite a few gaps in what we thought was being controlled. Ventilation, water, how about care home IPC practices? We have plenty of evidence that water is a source of nosocomial infections, and those infections are not just from Legionella and Pseudomonas. Other gram-negatives will share the biofilm environment. So what is going on in the pipes behind your clinical washhand basins, the other sinks in your facilities, the showers, the baths, specialist equipment that's supplied by water, the dental water lines, cleaning equipment, air conditioners, ice machines? And what about the biofilms in your drains? So the 5 steps then are not so much about waiting to be in a crisis. I don't know if you've heard of Eisenhower's Square, where you can either focus on important stuff, which will get things moving forward and create change, or you can focus on the urgent stuff, which is usually where we are when we're in a crisis. So these 5 steps are not necessarily about being in a crisis. They should be part of your daily routine. And step 1, communication, collaboration, and cups of tea. Communication is the thing that breaks down the most easiest and often because we're in a crisis. Cups of tea, we don't have enough of it. You certainly don't have enough of it because you're running around all the time. But hey, take that time. Because look at time as an investment to understanding. Who knows, who cares, and who will take ownership when push comes to shove. Then have a look at what the current reality is. This is obviously your gap analysis. But what is getting in the way? Is it the environment? Is it the processes? Or is it the skills of the people and their motivation? That's gathering data. And once you've gathered the data, then you've got step 3, defining what the improvement is that you need right now. And then once you know what the improvement is, by how much and by when do you want to achieve it? Of course, if you've defined an improvement, it usually ends up being a goal, but you need to know what actions in order to achieve that goal is going to be. So what has to be done, who's going to do it, and why isn't it already being done is the other question you should be asking, because that will identify the bottleneck which links back to step 2, your current reality and your gap analysis. And step 5, well, no point in putting all these things in if you're not going to evaluate what's going on and how the impact of your interventions or actions actually can be measured. This is your evidence and your proof going forward that you need extra support, you need extra help, extra resources, whatever it is. Think of how to evaluate it. So my intention today was not to give you the answers, because there is really no one size that fits all. You each have different buildings, different patient and staff demographics, and different cultures. But you might want to be thinking about some of these questions. Should this water be this colour? I know it sounds simple, but it's amazing how many people open the tap and don't see that it's brown. Should this water smell like this? It shouldn't, okay? If it's got a smell to it, it shouldn't. Where do people dispose of their liquids? And which outlet should the liquids actually be disposed of? Have you watched people throwing the patient waste fluids down the clinical washhand basins? Yeah, no. But that's what's happening. So it's where should they be? Which outlets should they actually be disposing of this fluid? And what about the cups of tea and the coffee? Where's that going? So why is there a filter on this water outlet? Do you know? Does anybody ask? Who's flushing the outlets, and how do you actually know they're really doing it? Is it just a tick box exercise, or has somebody got some digital monitoring in place that actually can tell you when these outlets are being flushed, for how long, and what the temperature is, etc.? And why are items stored around the whole hand wash basin? How many times have you seen the soap dispenser and the alcohol dispenser, and then there's something else that's usually around the back of the sinks? Why are they there? They're pooling water, and that's a great place for your Pseudomonas to be sitting. This room's empty. Who's actually running the taps and the showers whilst it's empty? And when was it last done? And what's happening over long weekends and public holiday periods? Amazing how flushing doesn't occur during that time. And you've just received your water results, but have they actually been passed to you in real time, which is actually when you want it? Or has there been a delay because the estates and engineering department think, oh, we'll just fix that and then we'll tell them afterwards? By then it's a bit late. And then you've got a report that says it's high counts, but what remedial actions have actually been instigated? Has that been communicated to you? You need to know, because you need to know what your clinical next step is going to be. So I talked about culture. I talked about culture of a team and culture of a group. Well, the culture of a group or organisation is usually translated in the way things are done around here. And the way we do things is really a reflection of the values, the beliefs and the behaviours of the current leadership and the legacy of past leaders in the systems and processes that have been created. We can't control everything, but we each are leaders in some way. So it's our culture, it's our values, and it's our beliefs that we can impart onto others. We do need policies, systems and processes, but these will not work without the human beings taking action on them. So this is why it's so important to understand what is getting in the way of them doing the right thing and how are we actually helping them make those systems and processes work. In what often feels like a time-constricted world, it is time that is the real currency. If we invest time with the intention to learn and understand what's going on around us, appreciate the roles of other people in our team, the different languages that they speak, the perspectives and challenges that they have, we will be better prepared to prevent avoidable infections, including those from water hazards. Additionally, in the event of an outbreak or an incident arising, having more awareness and appreciation of the members of the multidisciplinary team will enable a rapid response from the whole team, with control measures already in place and understood. So in the midst of our frustrations, when things aren't going the way that we hoped or planned, this little mantra from Mindful Meditations may offer some guidance and perspective, and it's certainly helped me when I've watched things going on. Everyone is doing the best that they can with the limited knowledge, skills and experience they have right now, and this includes me. So before I go, I'd just like to tell you a little bit about the Central Sterilizing Club. It was founded in 1960. It was the original decontamination forum, and from this forum came Infection Prevention Society, HIS, and the Institute of Decontamination Sciences. They've all emerged from our Central Sterilizing Club. The first chair was Professor Darmody, who was a senior pathologist at Portsmouth. And then we had Professor Graham Aycliffe, who chaired it from 1986 to 1989, who's one of the UK's eminent microbiologists, infection control. And one of our CSC members, John H. Bowie, he was the first one to develop a pre-vacuum sterilizer, the Bowie and Dick test as a monitor of autoclave performance, and also the autoclave tape. The club has really grown. With enthusiastic individuals, and we are representative from across the whole team. We have authorising engineers there, we have infection control specialists there, we have the commercial representations there as well, we have the clinical microbiologists, we have as many people as possible from the whole team because we believe in a whole team and we all have different skills and knowledge to share. We meet only twice a year. One's our annual study day and the other one is our annual general meeting, and we would like to invite you to become a member for just £30, but actually it's not actually £30, it's £20 if you get in there in the next 6 months. So we'd really appreciate any input from everybody. Our next study days are these. We've got one in October, which is going to be decontamination, is it sustainable? So we're really going into, I heard today on the food waste and the waste side downstairs about sustainability and net zero. We're very aware of this because the decontamination processes of reusable medical devices is quite labour intensive from both energy, water, labour. So we're having a study day on that this year, and we'll be holding our annual scientific meeting in Newcastle upon Tyne. And it just remains for me to say thank you very much. I really appreciate your attention today.